Welcome to another installment of the IBD GECO meeting. I'm told that we had 50 registrations. We have representation from Zambia, Kenya, Ethiopia, Nigeria, Mozambique, and even an individual from Benin. So welcome, and we hope you will continue on this journey with us. We have 33 people that are online, and hopefully more will join as we go along. I have previously spoken about Project ECHO and what it aims to achieve. And briefly, it is a model of continuous medical education, and it links experts based at academic centers with physicians managing patients where they're at to provide knowledge, but also support, particularly in the management of difficult conditions. And I think we would all agree that IBD is one such complex disease. In this context, I think I would like to congratulate the Gastro Foundation for having supported and facilitating such a venture. Today, we have a didactic lecture that's going to be done by Professor Watermeyer. She has previously presented on this platform. So she's going to give us a talk, after which we will take questions. And then we're going to have a case presentation by one of our fellows, Dr. Kochia, based here at Groote Hospital, UCT. And then we will open the chat again for any questions that may arise from the presentations themselves or any other questions that might be relevant to your practice. So without further ado, I'm going to hand over to Jill for her presentation. Thank you so much.
Okay, right, can you see me? Mash? Okay, cool. All right, so I'm going to discuss the best use of anti-TNFs in 2020. So the anti-TNFs have been with us for some time. The first one approved was infliximab for Crohn's disease in 1998. And subsequently for Crohn's, we had adalimumab and certolizumab also approved. And for ulcerative colitis, infliximab in 2005, adalimumab in 2012, and most recently golimumab. Now, I just thought it'd be quite interesting just to take you through the biological nomenclature, and this applies to every single biologic, not just to those that we use in inflammatory bowel disease. So I chose rituximab, which is obviously not used in IBD, as an illustration. So if you look at the first part of the word, RITU, it's got no real meaning. It just has to be unique to the specific biologic. XI, that's the second part. That means it's a chimeric molecule. One can also get a U or an MU in that place, which means that the a monoclonal antibody is fully human. And if it's a ZU, it means it's partially human or humanized. And of course, the MAB at the end means monoclonal antibody. So infliximab is a chimeric IgG1 monoclonal antibody. You can see the XI in the name. This means that it is partly murine. The antibody fragment is from a mouse. And this, of course, will increase immunogenicity, and it is given intravenously. Adalimumab and Golimumab, you can see the MUs in the middle. This means that they're fully humanized antibodies, which means that they're less immunogenic than infliximab, and they can be given subcutaneously. And finally, certolizumab, which is not used very widely across the world, mostly in the States. And the ZU there, you can see that it's partially human. The reason being it doesn't have an FC region. It's the antibody binding fragment combined with polyethylene glycol. So there are three key issues with anti-TNFs. Firstly, efficacy. Secondly, immunogenicity. And of course, safety. So all of the anti-TNFs have been proven to be effective in inducing and maintaining corticosteroid-free remission, in endoscopic improvement, and for Crohn's disease for healing fistulas. And these are the seminal randomized controlled trials upon which registration was based. In all of these studies, the various anti-TNFs were shown to be superior to placebo. So if one looks at Crohn's disease, there are no large prospective head-to-head studies of the different drugs to see if they are comparable. But I think having a look at these diagrams, it looks pretty similar remission data for all of them. And I think one can quite safely say that they are equally efficacious in Crohn's disease, and this is supported by a wealth of post-registration data. And the choice really depends on the patient and the physician's preference. For example, do they want to use subcutaneous or intravenous preparation, availability, and needless to say, cost. In ulcerative colitis, not quite as clear. Certainly for patients who are biologically naive, infliximab is definitely better than adalimumab. And if you look on the right there, in patients who've had previous infliximab exposure, tofacitinib is in fact better than adalimumab, vedolizumab not coming in that closely. So this network meta-analysis has been updated to include ustekinumab because we now have data from the Unify study. And in fact, ustekinumab comes in the previously infliximab exposed patients around about the same as tofacitinib. Okay, so this is just another way showing the comparison of the anti-TNFs in UC. And if you look in induction, in the red box is the infliximab data from the Act 1 and 2 trials. And I think just at a glance, of course, it's comparing apples with pears, but there are no prospective head-to-head studies. I think you can appreciate that it definitely works better in induction and in maintenance in patients with ulcerative colitis. So this is echoed in the recent AGA guideline on the use of biologics in moderate to severe ulcerative colitis, and they suggest using infliximab or vedolizumab rather than adalimumab. Just to mention that, of course, in the setting of acute severe ulcerative colitis, infliximab is the only anti-TNF that has been evaluated in randomized controlled trials and is the only one that is currently recommended for rescue therapy. How do we go about optimizing anti-TNF therapies? Well, first and foremost, I think we need to treat as early in the disease course as possible because we know that treating early yields better results. And this makes perfect sense because the earlier in the disease that you treat somebody, the less likely they are to have irreversible complications. And this is just some data from adalimumab showing that patients treated within 2 years of diagnosis did much better than those who had a more extended disease course. And this has basically been shown for every single one of the biologics that we have. So now anti-TNFs are high molecular weight proteins. They're produced in living cell lines through a very complex manufacturing process. So basically the human body recognizes them as being foreign and results in the production of anti-drug antibodies, which are associated with deleterious consequences, in particular hypersensitivity reactions and increased drug clearance with loss of efficacy. One of the keys in maximizing anti-TNF use is to try and prevent the formation of anti-drug antibodies. And this is a core concept governing many of our current treatment strategies. So how can we do this? Well, certainly in the case of infliximab, we have been shown that the combination with azathioprine is better than either alone. And this is from the SONIC study in Crohn's disease, but we have similar data in ulcerative colitis, the SUCCESS trial, again, showing combination of infliximab with azathioprine is better than either alone. And this is largely due to reduced antibody formation from combination therapy, which results in increased levels of anti-TNF. In patients who have failed an immunomodulator and you now put them on an anti-TNF, you can in fact use a much lower dose than you would use for therapeutics, because here it is purely to reduce immunogenicity. So you can even go in with a dose of azathioprine at 50 milligrams a day, or methotrexate 12.5 milligrams weekly. In young men, there is always the risk of hepatosplenic T-cell lymphoma and B-cell lymphoma. In patients who are on combination therapy. So here it's probably wise to try and limit the thiopurine combination to 1 year, or alternatively use methotrexate, which is much safer. A little less clear with adalimumab. It is much less immunogenic than infliximab, and we have the only randomized controlled trial, the so-called DIAMOND study, which evaluated a combination of adalimumab and azathioprine compared with adalimumab monotherapy. And in fact, there was no difference in outcomes in comparison to the infliximab data that I've just alluded to. But importantly in the study, the azathioprine dose that was used was much lower than what we would use in clinical practice. Regardless of that, the latest ECHO guidelines, which came out towards the end of last year, suggest using adalimumab as monotherapy. But in my opinion, combination therapy has been associated with higher trough levels and lower anti-drug antibodies, and this has also been shown in the recently published PANS study in Crohn's disease. So certainly in our setting, if a patient has very refractory, complicated disease, where you really want to give them the best shot, I would still consider using combination therapy with adalimumab. So there are some people that you would want to use monotherapy because you really want to avoid thiopurines, and those would be patients who've had obviously severe intolerance or adverse effects. The elderly, because of the risk of lymphoma and other malignancies that thiopurines carry. Patients who've had a previous malignancy, thiopurines are probably our most dangerous drugs in those patients who've had a cancer. And young males who are EBV negative, because should they acquire the primary infection and they are EBV negative, they can go on to develop a very fatal, rapidly progressive lymphoproliferative type of disorder. So now obviously we can't treat everybody with all these drugs together. It's expensive and we have limited access. So we really need to be able to identify those patients who are likely to have poor outcome. And there are a number of clinical predictors. They're not perfect, but they do help us to see which are those patients that are likely going to deteriorate down the line. And for both diseases, it's young age, the need for steroids, and extensive disease. For Crohn's, it's also ileal rotation, perianal disease, stricturing or fistulizing phenotypes, and smoking. In ulcerative colitis, it's raised inflammatory markers and very deep ulcers at the index endoscopy. And these are the sort of patients that are high risk and the sort of patients that you would feel most comfortable really going in very early with your aggressive therapies. The other thing in order to optimize anti-TNFs is really to treat beyond just patient symptoms. Because we know that symptoms in IBD don't always reflect disease activity or disease severity. And this is especially true in Crohn's disease, where there's quite a marked discord between symptoms and more objective markers of inflammation, like CRP, fecal calprotectin, or endoscopic appearance. So until recently, our management of IBD really aimed at treating symptomatic clinical flares and maintaining symptomatical clinical remission. And by doing this, we basically ignored the large burden of subclinical disease, which ultimately was resulting in cumulative damage to the digestive tract. So basically, we need to target subclinical inflammation, ideally early in the course of Crohn's disease. And to do this, we need tight control and close monitoring of patients, even when they are asymptomatic. And hopefully in this way, we can reduce this progressive destructive digestive damage and disability down the line. And these are the sort of things that we obviously want to prevent, because once these happen, there's very little that medical therapy can do to change the problem. So hence the beauty of the treat to target strategy. And by this, we mean where a well-defined endpoint is selected and treatment is either initiated or escalated to achieve this and to maintain this independent of patient symptoms. It's a strategy long adopted in other chronic illnesses like diabetes and hypertension, which similar to IBD are also chronic progressive diseases, which if they're not treated effectively, even if asymptomatic, will ultimately culminate in end organ damage. So it's becoming more clear that early optimized treatment and tight control can give us an opportunity to prevent complications and disability. Now, the targets in diabetes, hypertension, they're well known. We use them every day in clinical practice. But what are the targets in ulcerative colitis? Well, the first attempt to define this came in 2015 with the IOIBD STRIDE recommendations. At that point in time, it was suggested that for Crohn's disease, we should aim for patient-reported outcomes of normal stool frequency and no pain. In UC, normal stool frequency and no blood per rectum, as well as mucosal healing. Now, it was called mucosal healing back then. It's no longer called mucosal healing. Mucosal healing as an endpoint now implies endoscopic improvement and histological remission. So instead, what was called mucosal healing, to be correct terminology, it's now called endoscopic improvement. It was also suggested in the STRIDE guidelines that for patients with Crohn's, one should try and get cross-sectional imaging to evaluate the gut beyond the reach of scope. So the influence of endoscopic improvement and outcomes, this has been known for a long time. This is a Norwegian population cohort, the Ipsen cohort. And the importance of this was that it was done in the pre-biological era. And it just shows that achieving endoscopic improvement by any means is valuable. And in both ulcerative colitis and Crohn's disease, there was fewer surgeries. And subsequently, there's really a wealth of data showing that endoscopic improvement or endoscopic remission is associated with improved clinical outcomes and reduced complications. Following on from the STRIDE process, we did have the PALM study, which is now already almost 3 years old. This was a multi-center open-label study in moderate to severe Crohn's disease. And basically, there were 2 arms in the study. The first arm, patients were treated with adalimumab, and their treatment escalation was driven by their symptoms. and whether they required steroids. The second arm, which is the tight controlled treat to target arm, escalation of adalimumab was driven not just by symptoms and prednisone, but also in an attempt to normalize the CRP and the fecal calprotectin. And essentially the primary endpoint, which was endoscopic, showed a much higher, achieved in a much higher proportion in patients in the treat to target arm, as opposed to those who were just getting escalation based on predominantly symptoms. Also in the CALM study, all of the secondary endpoints were also met, and the delta for deep remission was 14.5%, and there was also significant corticosteroid-free remission at all time points. So I think certainly CRP and fecal calprotectin and normalization of these are definitely targets, as well as those mentioned in the STRIDE consensus. So basically, we need to monitor our patients closely to ensure that these targets are achieved. And this would obviously mean taking a history, making sure your patient's symptoms are under control, and then also looking more objectively at CRPs 3 to 6 monthly. We tend to do them at every visit. And endoscopy after you either initiate therapy or escalate therapy. So STRIDE recommended at 3 to 6 months in patients with ulcerative colitis and 6 to 9 months in Crohn's disease. Of course, some patients are going to be rather unhappy having an endoscopy every time you change their therapy. And this is where fecal calprotectin is excellent, because it's a very good non-invasive marker of mucosal healing, and you can avoid endoscopy. And here I use mucosal healing in the correct term, because it is a marker which correlates well both with endoscopic improvement, endoscopic remission, as well as histological remission. Okay, and then again, as I alluded to, regular cross-sectional imaging in Crohn's disease in patients who have disease that is beyond the reach of the endoscope. But just to finish off, anti-TNFs are not the holy grail. We all know that 30% are primary non-responders, 40% lose response over time. They're expensive and they're not without their side effects. And I'm not going to discuss the safety issues of anti-TNFs today, because there really isn't sufficient time to address that adequately. But we now have therapeutic drug monitoring, which is, of course, the measurement of Prof levels and anti-drug antibodies. And I believe that reactive TDM is now standard of care in those patients who failed to respond initially, and those who have done very well and now have secondary loss of response to the anti-TNF. I'm not going to discuss proactive therapeutic drug monitoring. It remains controversial, and I, for one, am fairly confused about how to use it. So this is just what we look at with reactive TDM. If you have low trough levels and there are no anti-drug antibodies, clearly you do not have enough drug on board to treat the disease, and you need to increase the dose or shorten the interval. If you have low trough levels and there are positive anti-drug antibodies, this is particularly if they're high, then increasing the dose will not work, and you need to switch to another anti-TNF. If the anti-drug antibodies are very low, they're often non-neutralizing, and you can actually solve the problem by, in that case, increasing the dose or adding an immunomodulator. But once you have very high titer antibodies, it's really not going to be effective, and you need to switch. And then finally, you have patients with either normal or supratherapeutic trough levels, and clearly here their disease is not being driven by tumor necrosis factor alpha, but rather other cytokine pathways. And here you need to switch to another class. And finally, we do have other classes available. We have anti-integrins, and we have the IL-12, IL-23 inhibitor, ustekinumab. What trough levels to target? Well, this is a moving target, and the optimal cutoffs are unknown, and every single society gives a different recommendation. So I'm not really quite sure. But there do seem to be incremental gains, and for adalimumab, I think you start to see benefits right up until a trough level of 12, and infliximab about 10. So if you can, obviously there's expense involved. I wouldn't give up on a drug until you reach those levels if you're able to. So in conclusion, anti-TNFs have revolutionized the management of both UC and Crohn's disease. They appear to be equally effective in Crohn's disease, whereas infliximab appears to be superior to adalimumab in ulcerative colitis. Infliximab is best given in a combination with an immunomodulator, at least for a 6-month period. The jury's still out about adalimumab, but I've already told you my personal preference because of the reduction in the formation of antibodies. Thank you very much.
Thank you, Jill, for an excellent overview of a really important topic. I see that we have 51 participants, so welcome to those of you who joined since the beginning of the meeting. The chat function is open for questions, but I think it's also okay to unmute if you prefer and ask your questions. I mean, while we're waiting for that, I do have a few questions, Jill. In terms of rescue therapy, so if you're using infliximab for rescue therapy for acute severe UC, could you just talk us through at how many doses should you actually give? Because obviously resource constraints are an issue and you might not have the resources. Yeah.
Okay, so there isn't really a firm answer there, Mash. So the rationale about giving higher doses, because obviously the standard dose of infliximab are 5 milligrams per kilogram. But if you've got a very sick colon and acute severe ulcerative colitis, the anti-TNFs really just basically pour out from the mucosa into the stool. So you often don't achieve therapeutic levels. So there is a thought that you could either go in with much higher doses like 10 milligrams per kilogram, or otherwise have a much more accelerated induction period. So perhaps 3 doses over a 21-day period. There really is very little evidence to support this. Intuitively, it makes absolute sense. What little data there is out there hasn't really supported it, but we really need a decent trial to actually see if this is the way to go. But as I said, intuitively, it makes sense. And if we could, certainly we'd be whacking in a lot more anti-TNF in these sick patients.
Yeah. I'm just wondering for my colleagues in Kenya, I mean, how many patients do you see with IBD? What biochemical tests do you have available? What medications do you have available? Do you have biologics? Do you have biosimilars? It would be really interesting to hear the experience of other people on the call. Anyone who's willing to comment, please feel free to do so. Please go ahead. Colleagues from Kenya and even our colleague from Benin, do you see this condition?
Very shy.
Indeed, we have a very silent audience.
Hi, Jill. It's Niall here.
Hi, Niall.
Hi. I've got a question for you on fecal calprotectin. I've just come out of the scope room.
Yes.
And just a young chap whose brother's under my care with ulcerative colitis. So he came now having some gut symptoms, change in bowel movements. And I was reluctant to scope him because his fecal calprotectin was 30 micrograms per gram, completely normal. CRP was normal. And I was quite surprised to find out that he's got quite a number of terminal ileal ulcers, so raising a concern for Crohn's disease in this chap.
Absolutely.
So how confident are you that we're not missing disease with a normal fecal calprotectin?
Absolutely.
What's the false negative?
Yeah, so the problem with fecal calprotectin in small bowel disease, it does not nearly perform as well as it does in colonic disease. So a normal fecal calprotectin wouldn't really rule out small bowel Crohn's disease. I'm very happy with it in the colon, but small bowel a little less so.
Now, can I ask, what was the patient's CRP?
CRP was negative. I can't remember what the exact number was, but it was not elevated.
Yeah, because my understanding is that some patients just don't mount a response. And so you either use CRP or fecal calprotectin and then do the follow-up based on the test that was positive ab initio. But if you have a patient who's got negative CRP and a lowish fecal calprotectin, then yeah, I guess you have to go with the endoscopic and histological findings. And of course, your imaging. How old was your patient?
He's 32.
Oh, quite young, yeah. Yeah, I think you have to go with the imaging then and just endoscopy and histology. Jill, I had another question. At UNTW this year, they spoke about trials evaluating infliximab subcut.
Mm-hmm.
What's the current evidence with that?
Okay, so the phase 2 trials were positive, and I think it's going to be approved quite soon. And obviously that will be a great option because one of the major drawbacks of infliximab is obviously the intravenous route. So I'm not sure how long it will be in the future, but it's certainly going to be available.
Yeah. And perhaps cheaper. I don't know.
I think so, but we can see.
Yeah. All right.
Hi, Mesh.
Hi.
Joe and Mish, can I ask a question quickly?
Prof, you're a bit faint. Maybe speak into the microphone.
Sorry, Joe, can you hear me?
Yeah, that's
Yes.
better.
Okay. Coming back to the use here, I mean, I think Mish raises a good point, because if this is rescue medication, after 3 days, we're going to give up biologic. And so there's no 0, 2, and 6 weeks, because you have to respond immediately. And therefore, maybe this higher dose is a better option, because you're going to give 1 dose and you want to watch this patient within the next 48 hours. You can't wait for 0, 2, and 6 weeks for him to develop. Is that correct?
Yeah, absolutely. As I said, my personal preference, if we could, and I don't want to, you know, our pharmacy has been very, very kind to us in the amount of anti-TNFs they've allowed us to use. So I think if we start going for 10 milligrams per kilogram, they're going to get a bit tetchy, because right now they allow us to use it in all of our in all of our acute severe UCs. So I'm still going for 5 milligrams per kilogram, but certainly if I was in the private sector or I had access to it in a more unrestricted fashion, I would most definitely do 10.
With the 5, you're expecting to see some sort of positive outcome if you're using 5.
Well, we do. We've pretty much salvaged most of our colons. So there's very few that we haven't salvaged. So the 5 does work. But as I said, intuitively, we know that it leaks into the stool. So you would want to give your patient the best shot you can.
And then on a second point, Mish and Joel, sorry, Stefan Schreiber and all of the guys presented the study of CTP13 subcutaneously versus infliximab intravenously. And you know, visible was also vedolizumab. So in future, it's going to be subcutaneously. Am I right? That's going to be. The patients don't have to come in for lay in an infusion ward. They can do it at home.
Yeah.
Yeah, of course.
I mean, I think intravenous might still be useful for patients where compliance is an issue. Then they're sort of forced to come in. But I think for the majority of the working public, obviously a formulation that allows them to do it away from the hospital and with corona considerations, I think would be welcome. Talking about acute severe UC, I'm just wondering how many people still use cyclosporin for acute severe UC, because, you know, they don't have access to biologics.
Well, if you don't have access, you have to use cyclosporin, or you must call the surgeon. So
yeah,
I think
I'm wondering if our colleagues are still, you know, having to use cyclosporin because of availability.
Jill, I think it's not a bad drug. Am I right? A lot of Europeans like cyclosporin.
Oh, absolutely. I mean, the benefit of cyclosporin is it's got a very short half-life. So if the person does have to go to surgery, they're not going to have an anti-TNF on board. So our surgeons would certainly prefer it because they feel quite strongly that anti-TNF or infliximab is associated with worse post-operative outcomes. The true evidence for that is up and down. I'm not quite sure, but they feel very, very strongly about it. So they would certainly like it. But you know, in our setting, measuring levels, getting patients back, it also, cyclosporin won't hold you over the long term. So you need to have some kind of an exit strategy. So you can't use oral cyclosporin or tacro for the long term. It doesn't hold. So that patients have to be able to either take azathioprine or 6-mercaptopurine if the trexate doesn't work in UC. You know, the other thing, which, and this is what's emerging, is to bridge it to something else. So, for example, to use cyclosporin and then move on to vedolizumab.
Yeah.
The future is going to be to bridge to the small molecules. Maybe not TOFA, but it's going to be definitely UPA.
Yeah. And just before we go to the case, I think it's important also to note that in patients who are not responding to medical therapy, just to make sure that you've excluded CMV colitis as a cofactor and treated. I think we had one patient recently or in December who didn't respond, and it turned out subsequently that in fact she had CMV. She ended up with colectomy. If there are no further questions on Joe's talk.
Ashiko, can I ask another question?
Yes, please. We're dying for questions.
Just another practical question for Jill. It's a 54-year-old chap who had acute severe ulcerative colitis in December last year and required infliximab salvage therapy, did well on infliximab induction, and he's now on maintenance 500 milligrams 8 weekly. I've scoped him and he has active disease endoscopically, although clinically is asymptomatic in in significant segments of his colon again. What would you do with this chap? I've requested infliximab levels today and antibody levels.
Yeah.
What would your choices be? He's 54. Would you consider adding azathioprine? Would you increase based on the TDM? Would you consider increasing the infliximab? Or would you change to a different class?
You need to escalate therapy one way or the other, because he's already had one severe acute attack requiring rescue therapy, and he's probably going to have another one. So you have to be guided by your TDM. So for example, if his levels come back as high and he's got no antibodies, I would probably switch him to vedolizumab. Ustekinumab actually works better, but it's not currently approved for ulcerative colitis in South Africa. It's only approved for Crohn's, but you could get it as opposed on Section 21. So first choice for me would probably be ustekinumab, but if not, then vedolizumab. Obviously, if the antibodies are positive but they're low, then you could certainly start some azathioprine. 54, I'm not too fussed. That's my age, so I don't consider myself too elderly.
Thank you very much for that.
Yeah, but I wouldn't start azathioprine over the age of 65. Definitely not.
Okay, so I'm guided by the TDM and then decide on what happens next.
Do you have access to Vedo now in private?
I haven't used it, but it looks like, in this chap, if the TDM warrants it, we might have to try Vedo here, but I haven't used it personally.
Okay. Thanks for your input. Appreciate it.
Mashiko, Dion here.
Go for it, John.
On my chat, it says the chat is disabled. I don't know if that's accurate or not. It might be why there are no questions, or is that purposefully done?
You're quite right. It does say chat disabled. Cheryl, please help us with that.
Thanks.
Thanks, Dion. But it's not a bad thing. It's quite nice to hear people's voices, and maybe they can even put on their cameras so that we can see who is. No chance, huh? I think let's go to the case, and then hopefully we can have more discussion afterwards, and we can sort out the chat story. Dr. Kocher, up to you. Please share your screen. Thanks.
Hey, hi, good afternoon, everyone. I'm just going to present a quick case. It's a patient that was recently admitted in our unit, and then I'll leave Prof. Sachedi and Prof. Watermeyer to just lead the discussion around it. Essentially, it was a 14-year-old boy who was referred from one of our surgical colleagues in Victoria Hospital, Mr. SV. He's currently in grade 8. He's from Steenberg and has never been outside of Cape Town. He's got no known medical comorbidities. He's never had any surgeries. And according to him, he's of sober habits and he's a non-smoker. He's also got no family history of inflammatory bowel disease or colorectal cancer. So he was admitted in Victoria about 3 weeks ago with the first episode of a perianal abscess. It actually spontaneously drained while he was at radiology during his admission. He was treated with IV antibiotics and his bum settled nicely. On further inquiry, though, he reported a 1-year history of intermittent watery diarrhea, abdominal cramps, and significant weight loss. He denied any fever, he had no oral ulcers, and he had no other extraintestinal symptoms. What was also noted by the surgeon who saw him was that he'd actually been given iron for the past year by the CHC, and that's how they were managing all of these symptoms. So he went on to have a CT abdomen based on his symptoms, which showed a markedly thickened cecal wall and TI with local reactive lymphadenopathy. At this point, I was called more to find out whether they should do a colonoscopy at Victoria. My feeling was that he was going to end up having one our side in any case. He was settling well on antibiotics and they were going to discharge him. So I ordered an expedited colonoscopy our side, and he subsequently had an MRI and MRE at the same day. And he was then subsequently seen in clinic formally by Prof. Watermeyer a couple of days later. So when she saw him, he's a very lean young man. His BMI was 15. He weighed 38 kilos. He had a blood pressure of 100/40. At the time she saw him, he was tachycardic, whereas when he had the colonoscopy a few days prior, he was actually stable. He was quite pale. He had no extraintestinal manifestations. Cardiovascular and respiratory systems were unremarkable. On abdominal examination, you can see that he had quite an erythematous area around his umbilicus. There was actually pus starting to form underneath it. He had severe tenderness and suprapubic fullness. And then just also of note, on the side, you can see his height and weight for age, and he fell on the 5th centile for weight and the 10th centile for height. So he was severely stunted for his age. In terms of his laboratory investigation, the white cell count was raised at 16.9. He had a microcytic anemia, which was in keeping with iron deficiency at an iron of 3.2 with SATs of 9. Fortunately, B12 and folate were normal. His other features of malabsorption was a slightly low calcium of 1.93, a low albumin, and then obviously he had a high CRP of 42. In terms of his infective screen, he was HIV negative. The rest of his screen was negative, and his Epstein-Barr IgG was positive. A stool sample that had been sent off before from Victoria, unfortunately, C. diff was done, but the stool was otherwise unremarkable with no cells and no parasites.
I think if one looks at these results, what was remarkable, I think, for this young man was the fact that the INR was prolonged, which one doesn't often see in patients with Crohn's disease. I'm just wondering if there are any fellows on the call, if anybody would venture a reason or an explanation for this abnormality. And also while you're at it, just noting the calcium also being low. So it speaks clearly to his degree of malnutrition. I mean, just to mention that vitamin K is absorbed in the terminal ileum, at least dietary vitamin K. And so I think that we felt was the reason for his elevated INR. And I think this is a point that Niall raised. Here you have a patient who has collections, but hasn't mounted a significant CRP response. I mean, 42 is not that high. So it may be that this is a patient where those markers are actually not going to be helpful. And as Joe said, for small bowel disease and also in fistulizing disease, those are not necessarily as reliable as you might find in colonic disease. Yeah, I think those are just the points that I wanted to make. Yeah, you can carry on. Thanks.
Okay, so obviously based on his new clinical features and the investigations, he was admitted. This was just the colonoscopy that had actually been done a few days prior. So Dr. Levine did the colonoscopy, and on PR there's actually distal stricture which he dilated with a pediatric scope. The anatomy was completely distorted, and there was sort of no way to identify what was ascending, what was cecum, and he was unable to actually find the ileocecal valve or the TI. It was completely destroyed with chronic inflammation and ulceration, so a lot of inflammatory polyps as well. The transverse descending and sigmoid were otherwise normal, but then down in the rectum there was some evidence of previous inflammation with pseudopolyps. The two images on the left are the area where the cecum/ascending colon are, and the two images on the right is the rectum. So the histology showed a chronic active colitis. There were no granulomas, no viral inclusions, and no AFBs.
Yeah. So once again, you know, you have a patient who presents with what would fit in perfectly well with Crohn's disease or TB. With this brunt of the disease in the TI and the cecum and the perineum. And, you know, without histology that tells you one way or the other, it really is a composite way of putting everything together to come to a definitive diagnosis. It's very hard to know. And so I think we assumed then, based on these features, Cecilia, that this is probably in keeping with Crohn's disease rather than tuberculosis and rather than any of the other long list of differentials for ileitis, you know, vasculitis and those sorts of things. And I think Prof. Watermeyer, when she saw this patient, it was a pleasure because the patient had actually all the investigations done. So it was easy to actually put the case together at the first visit. So Cecilia had expedited the investigations in this patient. Yeah, you can carry on, Cecilia.
Okay, so obviously because he's a pediatric or adolescent patient, guidelines suggest that they should all have a gastroscopy done, and our main differential was Crohn's disease. Fortunately, his gastroscopy was unremarkable. There was just a bit of pangastritis with cobblestoning, but the histo just showed mild chronic gastritis with normal duodenal mucosa. So the MRE that was done the same day as the colonoscopy, and initially it had reported wall thickening and enhancements involving the cecum and terminal ileum, tethering of the anterior superior bladder wall, suspicious for communication with the adjacent small bowel, and then he had perianal sinus tracts at 5 and 7 o'clock. Sorry. So this area here, you can obviously see that there's a lot of inflammation and matting together of the bowel. After he was admitted and we rediscussed him with radiology, they actually reviewed the previous images and an addendum was made. So unfortunately at that stage, there was already a cecal perforation that was communicating with a fluid-filled or gas-filled collection in the anterior abdominal wall. It just wasn't clinically evident at the time. So he also had an abdo ultrasound, which confirmed it. This was actually prior to them reviewing the MRI images. And obviously it was of a larger size. So he subsequently ended up having a perc drain put in the following morning with a partial decompression of that collection. So they actually put the drain in over the cecal area. And as they did it, the umbilical area actually opened up and pus was decompressed. So he actually responded well to that. He was put on intravenous antibiotics and he got the dietitian involved. And he's actually gone home now. So just in summary, this young chap, he's only 14 years old. We've assessed him as having Crohn's disease. It's complex fistulizing disease. It's got ileocecal involvement with proctitis and perianal disease as well. His disease has been complicated by iron deficiency. He has stunted growth. He's malnourished. He's also got intra-abdominal sepsis, which required perc drainage and IV antibiotics. And then it's not to forget the psychosocial burden. He's entering adolescence. He's at school. He's already missed a couple of days at school. And obviously he's only at the beginning of his sort of a disease journey. So the question which now is really what do we do in terms of his management? And our options are essentially, do we try total enteral nutrition or partial exclusion diet? And that's been shown to work for luminal disease, but not necessarily for penetrating. Do we start him on our immunomodulators as a thiopurine or methotrexate, bearing in mind he's only 14 years old? Do we go straight to biological therapy? And then our options that we have here is infliximab, which is obviously ideal for the perianal and penetrating disease. But our other option is the biosimilar Amjevita, which is obviously less expensive. And then finally, do we opt for surgery first and then look at immunomodulators post-operatively? So I'm going to leave it now for Prof. Watermeyer and Prof. Sachedi to discuss.
Thank you so much, Cecilia, for that case and for looking after this youngster. Jill, do you have any specific questions that or any sort of comments on the case in the way that it was managed and the options?
Okay, so obviously we've all been involved in the management of this young man. So what we decided to go for was to try exclusive enteral nutrition. I appreciate that it's not effective for the fistulizing part of the disease, but the reason there, it may just settle down some of the inflammation, and also this young man needs nutrition. So we decided that it needs to be for 6 to 8 weeks. I'm not sure if he's going to manage it, but that was an option. There is something called the enteral nutrition with a partial exclusion diet that has been effective in Crohn's. Again, yes, it has, but for this young guy, I mean, he's got an absolute train smash going on in his abdomen. It's just an adjuvant therapy at this point in time. He needs a biologic. And for me, first prize would actually be infliximab because of the fistulizing component. But I would definitely want to use it with an immunomodulator. And given that he's 14, I'm a little bit nervous about azathioprine, and I'd probably go for low-dose methotrexate just to reduce immunogenicity. Right. Surgery, it's going to be a whopping operation. I mean, that's extensive small bowel. It may come to it down the line because we know that internal fistulae are actually very difficult to treat with biological therapy. But at least if we start with biological therapy, we can possibly downgrade all that inflammation. So if he does need surgery, it's not going to be a huge whopping resection.
Yeah. I mean, the chances that he might reaccumulate abscesses in the absence of sort of definitive therapy is high. And at the same time, he'd be high risk for surgery with his current nutritional status.
Yeah, absolutely.
Professor Casimides, I'm going to put you on the spot. If you manage this patient in private practice, what would be your first option and how would you manage this young man?
Sure, I absolutely agree with Jill. Jill, excellent talk, by the way, and Cecilia, fantastic presentation. Thank you. These sessions are really wonderful to be part of. No, in private, well, anyway, I mean, if you have access to biologics, that's your first choice. And I agree with Jill. I mean, I think that we're very concerned about using azathioprine in young adult males. Even if you use it for 6 months, but I would go with methotrexate and immediately an biologic, which in private will be available. So, and he should do very well. I mean, you know, stunted growth, they catch up very quickly, and yeah, I think that's the way to go. Jill, just one question. Fecal calprotectin and small bowel, we know it's not very reliable, but the situation which concerns us all is a patient with ileal Crohn's disease that has had surgery, and making sure that you pick up that recurrence early. And we know that evidence-based 6 months following surgery, you need to do a colonoscopy. But how good is fecal calpro? Because it looks as if it's panning out to be quite a good marker in that situation.
Yeah, absolutely, Chris. So I still don't think it circumvents the need for colonoscopy at this point in time. I still think at least once after the post-operative, they should have a colon. But I think going on after that, then I think fecal calprotections would be excellent for following up those patients and not having to do endoscopies on them again. But where I think it would play a good role in after that first resection is to do it at 3 months. And if it's positive, then you can bring the colonoscopy forward. So you're not sitting on a RIT gets 4 or a RIT gets 3 without escalating therapy. And if it's not high, then you could go and do your colo at 6 months.
Are there any questions or comments from anyone?
Actually, it's just one thing I want to bring up. When I did his opportunistic infection screen, okay, so his EBV is positive, so that's a good thing. But his varicella zoster was actually negative. So ideally, we should vaccinate him for varicella zoster. But if we did give him the vaccine, I believe it's 2 doses, or is it 3? I can't recall offhand. And you have to wait at least 3 weeks until you start immunosuppression. So that means we're going to be delaying treatment in this guy possibly for 3-4 months while we get this whole thing sorted out. So my gut feel is just to leave be. I don't know what your thoughts are on that. Would you vaccinate?
Yeah, I would tend to agree, Joel. There are going to be delays in his treatment for many reasons. So I think we do have time to be able to do that. The other thing that just struck me as we were talking is that in your last slide, you said biologics are not the holy grail. We know that the response rate is at best 40% and so forth. I mean, there's no question he needs it because of his fistulizing disease. My question is, do we now know what would predict whether he would respond long-term to this biologic therapy, or he may run into problems nonetheless if you project forward?
Yeah, so the predictors of what drugs will work for what patients, it's still really in its infancy. So there's not really any major predictors. One that I think that has emerged that is for me the most interesting is the HLA-A1-05 haplotype, that those patients are very likely to develop antibodies to anti-TNFs. And in that sort of scenario, you may want to actually use another class of biologic, but of course it's not really available, and I'm certainly not going to burden our laboratories by even requesting such a thing. But that's just one of the things, but certainly every week there's more and more predictors coming out about which drugs, and there are lots of different ones, especially for the new agents, but not really for prime time, I don't think.
Right. Mark Ostrovsky, it's lovely to see you. Hi. We do have some questions. How are you doing?
I'm good. How are you?
Very well, thank you.
Good.
We have some questions in the chat. Can you define to us the perianal region, and does he not need a seton drain? I mean, I think it was an abscess. I'm not sure that he had fistulae necessarily there, but it had drained spontaneously, and then he responded to antibiotics. So I'm getting the sense that he probably doesn't need a seton in situ. Would you agree?
Yeah, it wasn't. It certainly. It just looked like a little abscess cavity that was healing up at that point. I do agree that we probably should do an MRI of the pelvis just to make sure that we're not missing anything more significant.
That's a good point. The other question is the antibiotics that we used. I think it was metronidazole and ceftriaxone. Yeah, 10 days. Yeah.
Yeah.
Can you, okay, I've read that one. What about TPN to optimize his nutritional state and primary surgery? I think that's a good point. But he's taking enterally and he's tolerating it. And we can build him up slowly. Would you have gone for TPN, Jill? And if so, no.
I think you can get away with enteral nutrition here. If we were planning surgery and there was a little bit more of a rapid need to get his nutritional status, then I would think about it. But I think we can probably get away with enteral nutrition in this young man.
Yeah, I think so. Chris says, if this was isolated ileal disease, then surgery first. Yeah, I think that's a reasonable option. If he had limited in the TI.
100%.
I still think you would have to nourish him up first before subjecting him to surgery.
Your thoughts, comments on the Lyric trials coming out of Amsterdam?
Yeah, fantastic. So we're now seeing the follow-up results of the Lyric trial. It's now going a slightly longer term. And what is interesting is increasingly it looks like the surgical arm is doing better. In that so if anybody doesn't know, the Lyric trial compared primary ileal resection of ileal Crohn's disease with infliximab. And the initial results actually showed that it was cost effective and that it was similar quality of life. The longer term follow-up seemed to show that the surgical group are much less likely to require surgery or changes in their medication, as opposed to the anti-TNF group, where I think it was 47% of them landed up having an operation anyway. So it certainly has swung me towards, for that particular indication, short segment terminal ileal disease, that I would choose surgery. If it was me, I would want surgery for sure.
Yeah. Somebody, Igembe Ngandala. Igembe, maybe you could put on your camera and ask your question. It would be really nice to get to know colleagues that are elsewhere. If you are feeling shy, I'm happy to read the question out, but it might be better just to hear it from you. It is possible I butchered the pronunciation of your first name, in which case I apologize. Igembe, there you are. How are you? Oh, we can't hear you. Are you unmuted? I can see you, but I can't hear you. Yes. Yeah, go ahead. No, I'm afraid the sound is not coming through. I'll just have to ask the question for you. He says the child had a very low albumin. Considering clinical trials that have shown that albumin levels best predict response to biologics, would you consider cyclosporin and then shifting to biologics for maintenance? I don't think there's evidence for cyclosporin in Crohn's disease. And I think for us, we do have access to biologics. So for us, I think it would just make sense to go straight to biologics. Would you agree with that, Jill?
Yeah, absolutely.
Yeah. Okay. And the PERC drain, how long will it have to go with it? And after the PERC, what will be the timing of surgery since he already has a perforation? So the PERC drain did its job and it was taken out. Is that correct, Cecilia?
No, he went home with it and then we're going to review him in clinic and decide. He'll get reviewed by colorectal again. So
In
they
what
also...
interval?
Sorry?
In how long will he get reviewed?
I think he's getting seen this week in clinic for a decision.
Okay. And the decision on the perforation that he has and surgery at this stage, do you know what the surgeons have said?
As far as I understand, we're going to wait and trial the biological therapy first. Yeah.
All right. Mark, apparently you have a question. Apparently you have.
I just wanted to ask a question.
Yeah, go ahead.
Sorry. Would you consider giving steroids to him in terms of the fact that the varicella, we had to give the vaccinations first, we had to wait that period of time before we could actually give the biologic therapy? Would you consider a trial of steroids before that?
Definitely not.
Yeah.
We're trying to avoid steroids wherever possible, especially in a young man who's already growth retarded and with poor nutrition. And steroids don't do anything except treat symptoms, and they certainly do not treat intra-abdominal collections and fistulae. In fact, if anything there, that's pretty much a big contraindication to them.
Yeah, 100%, yeah. I'm mindful of the time, and actually for the first time, I would like us to finish on time. So unless there are burning questions or comments, I'd like to bring the meeting to a close. I do have to thank the Gastro Foundation and their collaboration with the University of New Mexico in Albuquerque. I really am grateful for the support we receive from the technical team in India, ECHO. Thanks a lot to Cheryl and Karen, who do all of the background work and make sure that everything works the way it's supposed to. 1,000 thank yous to all of you attendees. We really, really appreciate your interest and your participation. And as I said earlier, I really, really hope that we can build on this platform and get to know each other and just get to learn more about the experiences you have in managing these patients. Thank you so much, Jill, for your wonderful presentation as always and for your insights. I really, really appreciate it. Thank you, Cecilia, for putting the case together. It was very well presented. And just to remind you that they're going to post a link on the chat function for the survey. Really, please do tell us honestly. It is anonymous. We won't come after you. Please tell us how you're finding these meetings and what you'd like to see and hear more of. All of the talks, even the previous ones, have been recorded, and you can find them on the Gastro Foundation website. I believe I've said everything I need to say. And with that, I wish you a pleasant evening, and we'll see you next month with the last GECO meeting for this year. Thank you so much and take care.
Thanks, everyone. Bye.